Thank you for having me today. I'll be spending the next few minutes with you sharing some of the work I've done in the area of resident burnout and well-being. I have no disclosures to make, and what the next few minutes will look like are as follows here on the next slide. I'll be sharing with you some of the data on trainee and physician burnout, the prevalence, drivers, and consequences. Take a look at a number of the studies that have been done right here at Mount Sinai over the years. Then take a look at what some of the updates, what some of the well-being interventions are. I'll let you know a bit about what can be done to address burnout. And then finish by considering why all this recent attention, what's happening nationally to address this, why have the efforts evolved in the way that they have, and then take a look more locally at what we're doing here at Mount Sinai. But first, let's start with a case. Let's look at this 27-year-old second-year resident who was in her usual state of health until February, at which time she develops fatigue, loss of appetite, and insomnia. And despite this extreme fatigue from all the long duty hours, she's finding herself having trouble sleeping long stretches. She started to take zolpidem and diphenhydramine, and she even reports binge drinking on a number of occasions, once or twice per week. She reports that she hasn't spent regular time with friends in over 18 months, and recently she broke up with her partner. She's also now admitting to depressed thoughts 2 to 3 times per week. So this is resident burnout. This is not a particular resident that I'm thinking of, but rather that I'm sharing with you about, but rather an amalgamation of very commonly expressed issues and concerns that trainees have shared with me over the years, and also what we see in the literature. So with that, I will go to the next slide and show you really what many of you probably have seen for yourselves. This issue is really all over the place, and you see it in the lay press as well as the medical literature. Here's a piece in the U.S. News and World Report. JAMA's reported on this, Time Magazine, Are Medical Residents Working Too Hard, Doctors on Life Support, the Huffington Post, Physician Burnout. Surgeon General said, the former Surgeon General said, if physicians aren't happy, they can't heal others. So this is really everywhere. We're seeing it all over. And so the question becomes, when does burnout begin? Do we see this in the preclinical years of medical school? Does it happen with that often referred to challenging transition to the clinical years in the third year of medical school? Does it happen after medical school, in internship or beyond? And some have even invoked that this process might go back even further, that all the pressures and stresses that we place on young children to get into a good college, and then once in college, the pressures of getting into medical school are really at the genesis of this problem. So one can even consider that the beginnings of this happen at a very young age. So in terms of when it begins, this too has been in the literature, addressing the issue of medical student burnout. So we've seen this in New York Times articles, the American Medical News, Stress and Burnout, leaving some with thoughts of suicide, Gold Foundation, How Can Medical Students Deal with Burnout, U.S. News and World Report, It's not too early for medical students to think about physician burnout. So this is out there as well in terms of at what level it's starting. There's clearly interest in medical students that the process is beginning in medical school. So in terms of the literature, this is a large study done by Lottie Derby out at Mayo, where they've done probably 80 to 90% of the real big studies in the area. And they looked at a very large cohort of medical students, residents and fellows, and early career physicians. There were thousands of respondents to a survey in this study. And they were asked to complete a commonly accepted, validated instrument of job burnout. And then compared to kind of age match controls, age and sort of similar schooling population, college graduates were compared to medical students to get a sense of what are the burnout rates according to this instrument. And they also screened for depression. They used a PHQ-2. That's a whole other conversation about whether that's a real screen or not, and whether it's is it a diagnosis. But it's a tool they use. They also asked about suicidal ideation. And what I'll draw your attention to is that, oh, that's right, I can't point out here. What I'll draw your attention to is that medical students and residents had about a 50% burnout prevalence according to this. And you might say, that seems really high, but this has been replicated. There's been numerous studies showing that when you measure it, it's that high. And in the case of burnout, it was statistically significantly higher in students and residents and early career physicians relative to age, to the population control. And likewise, there was higher levels of depression in medical students relative to the general population. Also, residents had higher, actually all three groups. The early career physicians did not, but residents and medical students had higher rates of depression. There was not a significant difference found with regards to suicidal ideation. But this gives you a sense of the scope of the problem that we're dealing with. And a Medscape survey looking at faculty physicians found similar numbers. You know, sometimes people say, oh, well, I just need to get through training. I just need to get to the end, and then, I can take a break and life's going to get better for me. Or, I just need to get out of medical school and then I'll go into my, I'm applying, in dermatology because life's easy and great in dermatology and no one's burnt out. But I think what this study, at least for one, shows is that the prevalence is high in faculty. It's 37 to 53%, and it's pretty narrow, right? It's not like there's one specialty that's preserved from this problem. So what's driving it? I like this figure here because I think it really highlights the sort of multidimensional aspects of burnout. And what I also like about this is it shows that if those driver dimensions of burnout are optimized, you get someone who's engaged with their work, who has vigor, dedication, absorption. I'm sure everyone in the room who deals with patients can think of a time when they were really engaged in their work. They felt energized and excited to come in and do what they do. Certainly when these dimensions are not optimized, it can lead to burnout. It can lead to exhaustion, cynicism, and inefficacy. So at the center of all this is meaning in work, right? So that's what it is that drives our well-being, right? Is that we want to be doing something that has meaning, that has purpose. But there's so many other aspects to it, right? So there's workload and job demands. It was thought at one point that this is all about work hours. We just gotta control those work hours because residents, they work a lot, and if we can just decrease the amount of hours they work, then they're gonna be a lot happier. And the long and short of it is that didn't really pan out. There probably is a threshold above which it does make a difference. But it's not the whole picture. It's one aspect of it. And I think we all know that it's not so much a function entirely on how many hours we work, but what it is we're doing during those hours that we're here. Do you have control and flexibility over your job? Are you constantly being told that you have to do more and more things and you don't really have a say in that? Certainly a lot of people point to the electronic medical record that we can't actually go through a visit in the way we'd like. We're being told to answer certain questions and click certain boxes, and that is a big source of lack of control and eroded well-being. There's all the other aspects of work-life integration, social supports. What's your community like at home, at work? Is it a place that supports you or not? Do you have the right resources? What's the organizational culture? What are the values of the institution? Do they reflect importance placed upon your well-being? So all of those things are driving either engagement or burnout. And when they're not optimized, we're dealing with 50% burnout. What are the consequences? So this is why it's so important. This is part of the reason I believe there's so much national momentum right now, is that the literature has kind of led us to this inflection point where we really can say there's a lot of bad things associated with job burnout. And they can, in this diagram, nicely be divided between those that are personal and professional. And I think this also can help in terms of who it is you're making an argument with about why this is important, right? So obviously it's all important, but different power brokers have different demands on them that they need to answer. And so
this kind of lends to the issues, the consequences that affect the argument you might emphasize. But things like from the case, broken relationships, alcohol and substance abuse, depression, suicide in very severe cases, all these things have been linked. And then likewise, the professional consequences are really important. So there's a link to decreased quality of care, more medical errors, decreased patient satisfaction. And then in terms of the financial health of a system or an institution, there's less productivity, professional effort, and increased turnover in places that have more burnout. So in terms of, I want to draw your attention to one study that recently came out as it relates to one of the consequences, and I think it's important. I pulled this out because of how important I think it is. There's mental health and there's well-being. And these are related but distinct. And so you can have a resident who is clinically depressed, you can have a resident with suicidal ideation, and that person is similar but perhaps very distinct from the average resident who is just kind of burnt out from their work, right? So if we take a moment thinking about the mental health aspects of it, this is a study that recently was published, same author, out of Mayo Clinic, and they used the AMA master file and sent out a survey to far and wide to lots of physicians, and then they looked at the state those physicians came from, and they looked at the medical licensure applications, both an initial application and renewal application, and as I'm sure many in the room can recall, those applications in many states ask you about a number of things, but they ask you have you been under treatment for a psychiatric diagnosis, amongst other things. And so what this study found was that 40% of physicians were reluctant to seek care, mental health care, because of the fear of repercussions, specifically related to knowing that if they were to seek care, they would have to answer those questions. They would have to say, yes, I have a diagnosis for which I'm treated, and and face potential the belief at least of repercussions. And sure enough, they found that in the states that had more of those questions on their licensure exams, there was a greater reluctance to pursue care. So this is a really important issue. There's actually people that are addressing this issue specifically and trying to get those questions off the application. I mentioned before, and I pulled this study out as well, which is looking at professional satisfaction and career plans. So it turns out, again, from a very large survey, they got about a 20% response rate, but still they got about almost 7,000 responses. 20% of respondents were likely to decrease their clinical effort in the next year. And 27% said they were likely or definite to want to leave their practice in the next 2 years. 2% said they were going to leave medicine altogether. And burnout predicted the intent to reduce, so there was this correlation. If you were burnt out, you were more likely to want to do these things. So huge implications, right? We have to address this stuff because of the implications to the workforce as well. All right. So that's a bit of background. Let's talk about what's been done here at Mount Sinai, just to kind of let you know what it is that's done. And I'll highlight some of the work of folks in the room. Becky Mazurkowicz is no longer here, but she is still in medical education at Lenox Hill. Conducted a survey study of third-year medical students back in August of 2008. They were asked to complete a survey that included a number of things. What I've pulled out for you here are the burnout numbers. So on that survey was this validated measure of job burnout, and 71% of third-year medical students met criteria for burnout as used commonly in the literature. One of the ways we use a threshold. In August of their third year, right? So they hadn't really done much on the wards yet, but maybe this was reflective of that pretty high stakes time leading up to taking step one, and so that could certainly be a part of it. As you can see, Rob Fowler was involved as a co-author on this study, and has been on most that we work together, just to embarrass him a little bit. So another study that Rob and I worked on with some other folks here and also at Elmhurst, we administered a similar survey with that instrument. It's called the Maslach Burnout Inventory. we administered that at intern orientation. And we did that for Sinai and Elmhurst interns. So day one, fresh intern arriving, we gave them this survey. So it turns out you get pretty good response rate at intern orientation when you ask people to complete surveys. We did consent everyone, IRB approved, but at intern orientation they're eager to participate and help. So 34% met criteria for burnout before ever setting foot in the hospital as a resident. So that tells you something is happening leading up to the start of training, such that before even arriving, there's a cohort that's already experiencing burnout. So there's a problem here, and the problem begins before training in some cases. We did another study here after the implementation of the 2011 duty hour restrictions that went into place for all ACGME accredited programs, in which there were some, as I'm sure everyone knows, there were some new guidelines that put further restrictions on the hours that trainees work. There were some specific guidelines for interns in terms of total shift length that they could work. So this was an opportunity, sort of a natural experiment, because we had data prior to those work hour limitations going into effect, to see if work hours made a difference. And this is getting back to the comment I made earlier. So in our study, it did not. What we did is we surveyed internal medicine residents here and at 3 or 2 other institutions in the Northeast, sort of similar types of programs. And essentially what we found is that, let me see if this does that. Yeah. So we looked at burnout incidents. So we took those trainees who had no burnout at the start of internship at intern orientation and then surveyed them again at the end of internship year. And we had data prior to those work hour limitations going into effect, in which 81% of those who had no burnout eventually developed it over the course of internship. And that came down to 68% with a p-value of 0.07. So however you slice this, I think it's interesting. If you could say, okay, well, maybe a few more surveys and it would have been 0.05, and you could say something's happening here, which, okay, so that's great. But then if you're saying something's happening, what is it that's happening? Well, your incidence is going from 81 to 68%. So it's not like you're solving the problem. Maybe you're having some impact. And I do believe, and there's other studies that have shown this, that work hours do have some impact. Okay, so what's being done about it? I only have a few slides on this, and I'm just going to kind of talk about it in terms of some categories of options for interventions that have been studied. So I already mentioned work hours. That's kind of a system level intervention, and you can really, I try to think of interventions as happening on the individual level and on the system level, right? So an individual level intervention might be a physician, a resident, a student who decides, I want to get trained in mindfulness practices. And 5 years ago, I would say mindfulness, and no one would know what it is, but I would gather that probably everybody in the room has at least heard of mindfulness. It's basically a technique in which it's sort of based in meditation, and has some Buddhist origins to it. But essentially, it's a way of training your mind to be in the present moment, so that anything that happened yesterday you're not thinking about it for now, and all that work that's piled up waiting for you, you're also not thinking about it. You're in the moment. And you can train yourself and train your body to be in the moment, and this stuff works, actually. For people who want to do it, who engage in it, it does decrease burnout. And so we actually offer it here in a number of venues. What about reflection? So reflection can be done in any number of ways. It can be between peers. You can just get a group together, give them some time, and say, why don't you reflect on any of a number of stressors. It can be facilitated, as is being done right now through some folks in the room, through some studies, where you bring someone who facilitates a session around a stressor and guide a discussion that gives an opportunity to voice and decompress. Narrative medicine would be another example, balance groups, process groups. I put all of these in the category of sort of reflection-based interventions. And that too is sort of an individual. You as an individual decide you want to attend a group like that. I firmly believe these shouldn't be mandatory sessions. They should be strongly encouraged. But you want people who want to be there to participate in those types of sessions. And so that stuff works as well. There's been some evidence to show that works. So what I put here, it's a typical slide that nobody can read, but it's what I wanted to share is that there are now 2 essentially systematic reviews, meta-analyses that were published, both published at the end of 2016, that have one in JAMA Internal Medicine, which was this one, and another in The Lancet, that's kind of put together all that we know in terms of intervention specifically directed at physician burnout and trying to say, on balance, do these things work? And so they in this study, they broke them up into system-level interventions, like work hour changes, but also communication strategies, improvement in team-based care, those types of structural system-level interventions that can improve your flexibility and the way in which you practice. So these obviously were more for practicing physicians than for trainees. But the system level, the studies that looked at those kind of system level impacts had a greater impact. They favored the intervention greater. That's the top the top part of this forest plot. It's broken into system level interventions on the top and individual level interventions on the bottom. And so they both were effective, but perhaps not surprisingly, and we all know this, it's the system, right? So, and what I like to say is, you can carve out a mindfulness session for a trainee and give them the time to participate, encourage them, build it into their schedules, and they can attend all the sessions. But when they're done, they're going back to that clinic where the patient hasn't been given their vitals, they haven't gotten their vitals, and they need to be calling for a prior authorization, and they're helping to schedule an appointment. Excuse me. All those things that just are not really, they're all those clerical and administrative, all the epic stuff that they have to do, all that burden is there. It hasn't gone away. And so we need to do both, right? We need to address both aspects of this. But I would argue that if you're going to choose one area to focus on the system for now, figure out what are those main drivers and see how you can unload that burden. It's a challenge because if the trainee is not doing that, someone else has to be doing that work, right? And so either that's asking someone else who's already there to do that work, or it's hiring somebody to do that work. So that costs money. But that's also where you're likely to have more impact, at least from what the literature suggests. I put this study on here as well just to highlight this issue with regards to the electronic health record. Because essentially what this study did is it followed a group, I think it was about 60 physicians. It followed them around, asked them to kind of journal about how many hours are they doing what tasks, how many hours are they on the computer, how many hours are they with patients, direct patient care. And it also had like one of those wrist things that could, like, I guess a Fitbit or something like that could monitor. It could, I guess, determine if you were typing, perhaps. It could determine sort of the types of activities you were doing to some extent. And essentially what, the take-home from this is that for every hour of direct clinical care that the physicians had, they had 2 hours of electronic health record desk duty, right? So it's this 2-to-1 ratio. So when you think about those driver dimensions of burnout, and at the center is meaning in work, this is not, we didn't get it, we didn't say, I want to be a doctor so I could spend a third of my time with a patient, right? That's not why most people want to be doctors. So the other thing they highlighted, through the journaling and the Fitbit, was that all the work that happens at night, right? So the electronic health record is sort of, in some ways, it's freed us up in that you don't have to stay at work. For those that remember writing notes, you didn't have to like stay at work because that's where the chart was, so you could write your note, and then that's when you left. Now you can go home and finish your note at home. On the other hand, so there's lots of people, probably many in this room, who they finish their workday, and then you go home, and maybe you're dealing with something, something or responsibility around the house, and then somewhere later at 9 or 10, you're doing your 1 or 2 hours of pajama time, as they refer to it, and getting back on the computer. So this is a huge problem. It's a huge problem, and addressing the electronic health record is another system-level issue that I think everyone probably can give personal attention. All right. So why the increased attention? And then I do want to finish by sharing with you what we're doing here at Mount Sinai in the Office of GME. We have Frank Baslow in the room, our Assistant Dean of GME, who's really done a huge amount of work to enable a lot of this. I've probably made the case already. Why is there increased attention? This is a serious issue. There's sort of 4 big issues, I think, nationally that are driving this. There's the moral imperative. There's the business case. There's the implications of optimal health system functioning. And then there's ACGME is simply saying, you need to do this now. They've made it part of their common program requirements that we have to address the well-being of our trainees. And that does spur action. Is this a familiar photo to anyone? Sadly, we don't need examples from outside our own health system. But this was a photo, a video that was taken of an emergency room trauma physician. Is one of those that kind of went viral. Basically, he was, and he gave permission for the photo subsequently to be posted. But he was involved in a trauma in an emergency room in which a child died. And so this is sort of the immediate aftermath, where he didn't feel he could express himself that way in his workplace, his exact workplace. He had to step out and go to the parking lot where he broke down. And I think all of us, probably look at this and can remember feeling this way about a patient, about a clinical experience. This is the job we have. And this is the kind of toll it takes on us. So we need to speak openly about it. We need to normalize that. We need to make it clear that it's not normal to not feel this way at some point. What's the norm is that we all experience this, because it's the normal human range of behavior. We have psychiatrists in the room who can speak better to that than me. Dr. Muller just walked in. In terms of the moral imperative, we've had our own experiences here at Mount Sinai, very recently, in fact, where we're dealing with the impact of mental health on our own, and of mental health problems on our own. And so I do want to continue to draw the distinction between addressing burnout and well-being, because that's the majority of people who are in the workforce here at Mount Sinai and elsewhere, will experience some degree of burnout, perhaps, but the majority will never experience depression, and only a very few will have suicidal ideation. So that being said, these things are really raising the level of attention, appropriately so, to the issue. And here too, this was the piece from a couple years ago, the Columbia and Cornell suicides that took place. So clearly, there's a moral imperative to address this. Making the case to the C-suite, the C-suite also gets the moral imperative for sure, but they have all these other things to contend with. And so physician burnout affects all of these things that I showed you earlier: quality of care, safety, satisfaction. There's increased malpractice, and of course, productivity and professional effort. So we can't afford not to pay attention to this. Literally can't afford not to pay attention to it. There's real significant financial implications. This is a study from Tate Shanafelt. He's the chief wellness officer out at Stanford and kind of the real guru on this topic. Actually, there were 2 pieces in the New England Journal, I think 2 or 3 weeks ago, and he gave commentary and an interview on those pieces related to an effort that I'll get to in a moment. So I don't expect you to read this, but essentially what it shows is that what they did is they made the business case, and they give you these tables, and you can kind of fill in. You can kind of fill in the blank, like how many physicians are at your hospital, what's the burnout rate, which can be calculated using common instruments, what's the turnover rate, we can calculate that, how many physicians leave each year, and what does it cost when each physician leaves. So it might surprise you, it might not, but there's an estimate that it costs between $500,000 and $1 million to replace a physician who leaves an institution. It seems kind of astronomical, and I'm sure it depends in part on what kind of physician you're trying to replace. But when you think about it, in almost every, it's not like a physician leaves on a Friday and then Monday someone has filled their place, right? So there's all of that time that happens in between where you're having lost productivity, right? So if it's a 4-month period, that's 4 months in which patients could be seen. And so, I'm not an economist, but it's those types of figures that get rolled into calculating the cost of turnover. So you plug all that stuff in, you can do it. They gave an example in which there were 450 physicians, burnout rate 50%. Is that high? Well, I don't know. That study showed that it's 50% in a large national survey. We've got numbers here. I showed you the studies that we did here that showed similar numbers in our trainees. So a burnout rate of 50%, a turnover rate of 7.5%, and a cost of $500,000 to turn over a physician, you're losing over $5.5 million per year due to burnout. So that's the argument you want to make to the people that hold the purse strings. And then if you're a quality person, really we're talking about optimal functioning of a health system, right? So when the physicians are burnt out, the whole health system suffers. And it's not only important to the individual, of course it's important to the individual, but it's vital to delivering high-quality health care. If we're all about delivering high-quality health care, meeting the triple aim, which is patient satisfaction, population health, and low health care spending. That's the term that folks in healthcare system quality world, that's what you're striving for. We really want to meet the quadruple aim, which was a term coined by some of the folks in the wellness community, the physician well-being community, about how that's kind of the fourth dimension of optimal healthcare system functioning and quality. And then I mentioned the ACGME requirement. In a nutshell, they're asking us in the Office of GME and everyone involved in training physicians to figure out how to enhance meaning in work. Admittedly, some of these recommendations are vague, and I think they do that purposely. They want us to kind of run with it. But some of these things are not vague. They want to promote progressive autonomy, so an intern shouldn't be doing as much as a second year, as a third, and so on. Increased administrative support. They say, you have to unload some of this clerical and administrative burden off of the trainees. It is not good for them. It doesn't help their education, and it just makes them burnt out. I was at a meeting at the ACGME about 1.5 years ago, and we were discussing resident well-being, and in the room was the head of the ACGME, and so I asked him the question because it was curious to me. All right, so how do you? Yes, you have to unload their administrative burden, but how do you pay for that? And he said the hospitals have to pay for it. They have to pay for it. So, in other words, the argument there is that we the ACGME are an organization that we're an accrediting organization. That's what we do. We accredit. So we ask you to address these things. It's up to you to kind of figure it out. So in a minute, I'm going to tell you how we're trying to figure out how to do that. But it's up to us to figure out how to pay for it. Work intensity, work compression, still in there, right? So still important to think about work hours. Still important to think about what it is you're doing during the work hours. All right, so these are, some of you have heard of the wellness days, excusal for residents to receive medical care during scheduled work. What profession out there are you not able to just say, I need to take a day to go have a doctor's appointment? Like, there's no profession where it says, I'm sorry, like you have to get someone to cover you for 3 hours. So that was something that they said, you have to build that in. So we've built that in. In fact, every resident in the health system is entitled to a quarterly wellness day to attend to their needs. More education, provision of tools for depression, suicide, self-screening. We have some of those up. There's also a very robust effort underway to, and many of you know, to augment existing resources for student and trainee mental health here across the health system, which was needed and has been approved and is in the works. And then some of the things you're more familiar with, probably the 80-hour work week, the 1 day off and 7. So residents can now stay past the end of the shift to care for a single patient. What this gets at was feedback that the ACGME got after those first 2011 changes went into effect. Where there was actually a segment of residents that said, I don't want to leave. And so I think many of us who worked in prior to a lot of these requirements going into effect can remember that, you admitted a patient in the hospital, and it was that first 24 hours that everything happened, and, you felt a responsibility. And so I think there was a sentiment among some trainees that, I'm right in the middle of caring for this patient, and in order to meet like my work hour duty log, I have to leave now. So the ACG loosened that up a little bit to address that issue specifically. That if you're involved, you can do that. Good. So I'll just finish by sharing with you the national efforts, and then a little more specific about what we're doing and save time for questions. So. The National Academy of Medicine has taken it upon itself to create an action collaborative on clinician well-being and resilience, bringing together a huge number of experts to work on this. And this is likely to culminate, in fact, I'm virtually certain it's been approved. They're raising money currently to release one of their consensus reports. So probably most of you remember To Err is Human. That was their big consensus study that they wrote about medical errors, which led to a lot of change. So when they release products on topics, it often leads to a lot of change. And so I've loosely heard them refer to the next one as sort of To Care is Human, maybe the title of the one that's addressing clinician well-being. But there's a lot of work underway. They just had a webinar last week kind of highlighting. They have a web page and resources, and there's a lot happening there. Groups like the ACP, a very large, the American College of Physicians, very large professional societies have dedicated efforts to this. There are groups that convene and are developing products, and they have this is a snapshot of their web page, which is very robust and has lots of resources, which are really good. So that is out there. The AMA has taken on a huge effort. Chris Sinsky is their champion, who is an author on a number of the studies I showed you. This is their web page. They've been at it for a little while, and they're dedicating significant resources to this as well. So, everybody's talking about it, everybody's interested in it, and there is change in the works. So what are we doing here in the Office of GME? First of all, under Dean Lightman and the rest of the office, there was approval to create a subcommittee of the GME committee, which sort of oversees all things GME and has to give stamp of approval for activities that happen around GME training. So over probably maybe about a year and a half, 2 years ago, we created a subcommittee with a number of things that we wanted to do, much of which kind of overlapped with ongoing efforts, and kind of preceded the ACGME requirements. We sort of foresaw, in many ways, a lot of things we started working on were things that were highlighted in their requirements. So we kind of hit the ground running. But amongst other things, putting together wellness resources and measuring well-being outcomes. So these are kind of our current, there's things that have already been done, and these are our current projects. And so we really want to make it crystal clear when you have a trainee in distress, where do they go, who do they talk to, what resources are available. So that exists. We're still making sure that we're spreading the word on that and continue to spread the word on that. Putting together in a central place what wellness, there's all kinds of stuff happening in Mount Sinai. You probably get emails, about things that are going on, but we're going to try to centralize that a bit and add well-being to the dashboard for which all training programs here in the Mount Sinai Health System are measured. So it's going to be another metric that they need to meet, and so we're working on that as well. We created a document called the Expectations for the Promotion of Trainee Wellbeing. And when I say we, it was a big effort. Folks in the room were involved. And in really figuring out how to take the ACGME requirements and translate it into a policy that will be followed by the health system. And we broke it down into these categories, which I won't get into. We originally called this a mandate. We changed the name because, yes, we want everyone to do this, but we want them to do it because they know it's the right thing to do. So it talks about figuring out ways to unload administrative burden on trainees. It makes all the policies regarding work hours, leave, coverage, wellness days transparent. Addresses other trainee health needs like the availability and access of mental health resources, And we're rolling out, it's taking time because it's such a large system, but we are rolling out a menu of wellness offerings akin to those that I explained to you have evidence behind them, so like mindfulness and reflection, and others that are in the works. So that was a big effort by a lot of the members of the subcommittee that led to a really nice document, which I think fulfills the ACGME requirement. Faculty Wellness Champions. So Dr. Zbar was instrumental in this, and others, in creating a position. We are now in the midst of a pilot in which we have, it says 11, we have 10 wellness champions across specialties and across the health system, who are faculty that have excuse me, some support for their time to essentially implement the policy. So of rolling out the expectations of remote well-being. So they're kind of our pilot group to ensure and to help us figure out the best way to make sure these programs are up and running. So our hope is that at the end of this 12 months, the 12-month period, each of those programs that they're present at will be able to say, this is what we're doing for wellness. We have these wellness offerings. They're done at this time. Here's the curriculum. Here are the people involved, and here's what we're doing to unload administrative burden, etc. So there was a selection process. They exist, and that's up and running. This is nearly my last slide. So to address the administrative burden and the clerical burden that our trainees experience, which we know is commonplace, but is different in each setting, we've come up with a clinical intensity grant. And so many of you perhaps have seen this. The RFP went out last week, I think, if I remember correctly. And basically, we're looking to, in sort of a pilot grant fashion, support innovative ways in which programs are proposing to address that system-level driver of burden on our trainees. So, is it that they need, one more PA because they're staying late, they're being asked to stay late. And if we just have one person positioned in such a way, it'll unload a lot of work or a lot of work intensity. Or do we need a scribe to, help with charting because that's the number one burden expressed by another small cohort. And so we've created this grant. It's a matching grant up to $50,000, so a large sum of money, and we have budgeted up to 5 of these. So it's a large sum because the idea here that this is a system level. We want to get at the system. We're not looking for someone to say we want to set up reflection sessions. We want that too, and we have a way of supporting that. But this is really getting at what we think where the biggest return will be, and it's the system. So here are just a couple of examples of types of things that have been shown to have impact, and we think will continue to have impact. So please think about applying for that. And then measurement. We just yesterday sent out across the health system our survey. So we are going to, on an annual basis, measure common metrics of well-being, things like burnout, resilience, depression, engagement, using the types of instruments that are most commonly accepted, in this area to measure our trainees, and we're doing it on a program level. So we don't want to know individual. We do. We want to know about the individuals, but we want to know, for the interest of maintaining anonymity, we want to know if there's one program that might be, not doing as well in wellness as another. That way, we can approach those programs and provide assistance and help them develop their program. And this will inform our dashboard metrics that I was mentioning earlier, where programs are going to know. They're going to know that well-being is something that we look at, that's important. It'll be like a red, yellow, or green. Are you in the green? Are you in trouble? Are you? And it's not meant to say you got to be doing better. It's meant to identify those groups that where the needs are, basically. So with that, I will just summarize by saying that hopefully what I've shared with you, you see burnout is common in trainees. There's numerous drivers, lots of concerning consequences. Probably these multi-pronged approaches, the individual and the system level, multiple individual level interventions, because not everyone's going to want to do mindfulness or do reflection. But that's what's needed. And hopefully you got a sense that there's a huge momentum underway, right? There's momentum here at Sinai at the trainee level. There's new momentum at the faculty level, and there's momentum nationally. So I think it's this little niche subject that I picked up 13, 14 years ago has I guess I picked a winner. So that being said, it's been great to participate in all this, and with that I'll thank you and take any questions.